Today we're speaking with Dr. Robert Coleman, Professor of Medical Oncology at the University of Sheffield in the UK. He is Chief Investigator of the AZURE trial. The trial evaluated the effect of zoledronic acid on breast cancer. We want to point out that the trial funding and study drug is partially provided by Novartis Pharmaceuticals, but the study retains academic status. It has also been adopted into the NCRN portfolio of trials. Thank you for joining us.
Thank you.
There's a lot of excitement around the results of the AZURE trial, and I want to get to that, but first, can you give me some background on the bisphosphonate zoledronic acid? How has it been used and why was it chosen for this study?
Yes, well, zoledronic acid is a bisphosphonate that's widely used in the treatment of patients who've got spread of their cancer to bones with metastatic bone disease, both in breast cancer and other cancers. And it's a very good drug at building bone and protecting against the complications of cancer. But alongside the development in advanced cancer, there's been indications that perhaps a bone-targeted drug could prevent malignancy from returning by interrupting the vicious cycle between cancer cells and bone cells. We chose to study zoledronic acid because it's the most powerful of the bisphosphonates available, and in preclinical studies appeared to be the most promising. So it's given intravenously, and it's easy to combine with chemotherapy. And you know the patient's received it, there's no problems with compliance, which can be an issue with the oral agents.
Early evaluations of zoledronic acid suggested an anti-tumor effect when combined with adjuvant chemotherapy in breast cancer treatment. Would you discuss your final results?
Yes, our results are quite complex, actually. This was a large trial. The AZURE trial randomized 3,360 patients to standard breast cancer treatment alone or the same kind of treatment with zoledronic acid. And we were hoping that we would see an improvement in disease-free survival and recurrence rates. And our trial actually shows that overall that's not been achieved. There's no significant difference between the two groups of patients. But maybe we were a bit simplistic when we set up this study, and the idea that all women are the same and their breast cancer will behave the same is perhaps, in retrospect, a slightly naive approach. And what we've found when we've looked in this study in more detail is that there's very different effects depending on the age and the menopausal status of the woman. So for young women, this doesn't appear to be a very effective treatment, but for older women who've gone through the menopause, will have low estrogen levels, then this treatment appears to significantly reduce recurrences and actually significantly improve survival by nearly 30%.
Would you discuss how these trials all fit together, AZURE and ABCSG?
Yeah, the other large trial is, of course, the AZURE study from the Austrian group, and that was a positive trial. That was in young premenopausal women. And at first sight, our results in AZURE look completely different, and indeed they are very different. But so are also other populations. So the ABCSG12 population all received goserelin, which made them menopausal. And so biologically and endocrinologically, they're actually more like our postmenopausal women. So the benefit we've seen in our older patients is almost identical to the benefit that was seen in ABCSG12. And so we think that actually there are some very good parallels. What it does imply, though, is that if you were going to give a drug like zoledronic acid to a young woman, you really should be doing that with ovarian suppression using goserelin or oophorectomy.
What are the next steps in this drug?
Well, I think because the results are quite complex, there's a lot of discussion needed about how real are these observations we've made? Are they convincing enough to change practice? What are the mechanisms that really underpin what we've seen? So there's going to be a lot of thoughts about the biology that's going on. We're also going to look at some other studies that have either reported in the past or are about to report, and try and amalgamate the information using menopausal status as a criterion for splitting the data. And I think the other thing is to go back to some of the preclinical models and see if we can prove that bisphosphonates actually only work in a low estrogen environment, which is what our results in ABCSG12 would suggest.
Thank you so much, Dr. Coleman.